Awesome. Well, welcome everybody to part 2. We're going to be talking more about 340B. Let's see if I can advance my slides here. Awesome. So again, welcome to Hepatitis 340B webinar series. Please use the chat box to introduce yourself, ask any questions. This webinar is being recorded and it will be distributed at a later time. Everyone's mics have been placed on mute for optimal audio. Feel free to show your face if you want, safe space. If you don't want to, no pressure from us. And if you have any questions that you don't want to share in the chat box or discuss on this webinar, feel free to email us at hepatitis@nastad.org. It's up there on the slide. And again, feel free to introduce yourself in the chat. We're going to create a really casual, fun workshopping environment, so feel free to join in on the chat. And of course, special thanks to NASTAD staff on the call. We've got Alex, Watima, Edwin, Emily, Jasmine, and Tim. Thank you, NASTAD 340B experts. And for those of you who missed out on the first session, this is a series, multiple parts. I'm looking forward to chatting with you more. I'm a public health consultant. I'm also a former health department prevention manager and 340B authorizing official and primary contact. I've navigated the 340B program for over a decade, and I'm excited to be here with you today. Our webinar series will provide a detailed understanding of HRSA's 340B drug pricing program, and it's really designed to support viral hepatitis programs, but is also applicable to HIV and STD prevention programs as well. The overview of the webinar series is to really increase functional knowledge of HRSA's 340B drug pricing program, and identify the role for 340B drug pricing programs in viral hepatitis programs, understand the roles of health departments in the registration process, and operationalize the 340B drug pricing program in viral hepatitis elimination efforts. Again, you don't need to learn everything today. This is a multi-part series. Please don't be overwhelmed or stressed. We're here to help you. Future sessions are going to be on April 7th, 21st, and then May 5th as well. And we have the standing day and time, so it'll be Wednesday at noon for all of our sessions. Find my slide can move. There we go. So for today's agenda specifically, we're going to review the 340B basics. We're going to discuss the roles of the health department, and we're going to review the registration process as well as discuss special considerations. Of course, throughout this webinar, we're going to answer questions, and we're going to have time at the end for workshopping any issues if you want to present any to us. So to get us started off with our 340B basics, we are going to have a pop quiz. Let's see, if you could participate in the polling that I just launched. The first question in your pop quiz is, what federal agency is responsible for administering the 340B drug pricing program? Your options are CDC, GSA, HRSA, or the FDA. Our second question, signing up for the 340B drug pricing program provides covered entities with free medications. That is a true or false question. And then our third question, how many parts are there to the 340B drug pricing program patient definition? And your options are there in the poll as well. And I see 29, 30 of you have participated. Thank you. Does it feel like you're in college again with a pop quiz online? Excellent. I'll give you just a couple more seconds to put in your answers. Great. 90% of you have voted. So let's end our poll. All right, so 98% of you got the first question right. HRSA is the federal organization that administers the 340B program, not CDC, not GSA, not FDA. Number two, 93% of you got this one right. Signing up for the 340B drug pricing program provides covered entities with deeply discounted medications. Nothing is free in life. This does not provide free medications. Question number three, 58% of you got this one right. So we're going to review this one a little bit more in depth during this session. There are actually 3 parts to the patient definition that you need to be intimately familiar with. 24% of you guessed 5. I'm glad there are not 5 parts that you have to remember to the patient definition. All right. See if I can close my poll. Okay, can you just see my screen now, Isabel?
Yes.
Thank you. All right, the link to our last session is up there on the screen. I'm not sure if linked URLs transfer through Zoom. If not, we'll send it out to everyone. But we did 2 weeks ago cover 340B basics. So if I miss anything in the review or you're feeling completely overwhelmed, or if this is your first session, please feel free to go back to the first session, watch it, review, do what you need to do. We're also here to help with basics as well. So a summary, the 340B program, like I said, is a federal program administered by HRSA. It's the HRSA's Office of Pharmacy Affairs, OPA. The program was created in 1992 and requires drug manufacturers to provide outpatient drugs to eligible healthcare organizations and covered entities at significantly reduced prices, not free, significantly reduced. It was enacted by Congress and signed into law by George W. Bush. So this is actually a legally binding program. Eligibility is dependent upon receiving federal funds that are authorized by certain sections of the Public Health Service Act. Covered entities must have a financial relationship with a qualifying Section 318 program that is eligible for 340B and must receive either direct financial support or receive in-kind contributions. And it must be supported by the qualifying Section 318 funding. Viral hepatitis programs are in Section 318 of the Public Health Service Act, and they fall under the STD clinical designation in the 340B world. So this applies to HIV prevention programs as well as STD prevention programs. All of those prevention programs are authorized by Section 318. Eligibility is dependent upon the grant funding a provider receives, and patients must meet a 3-part definition. The covered entity must have established relationship with the individual and maintain records of the individual's healthcare. The individual receives healthcare services from an employee or paid contractor of the covered entity and is responsible for the care of that individual. And the individual receives care or range of services from the covered entity, which is consistent with the intent of the grant. And again, all grants authorized by Section 318 of the Public Health Service Act are eligible. That includes the Integrated Viral Hepatitis Surveillance and Prevention Grant, the HIV Surveillance and Prevention Grant, as well as the STD Prevention and Control Grant. Let's go through some scenarios to test your 340B program eligible knowledge. In our first situation, End the Epidemics Echelon is a nonprofit organization that participates in their state's planning group. They provide many HIV Hep C services to the community, and they take referrals from a lot of health department funded agencies. They have medical providers, they keep medical records on all their patients. They don't have any contracts, grants, or agreements with the health department. In the chat, let us know, do you think that they are 340B eligible? Should End the Epidemics Echelon enroll in the 340B program? In this scenario, the organization may be implementing activities that are in line with a qualifying grant, but they hate the government, they hate bureaucracy, they hate the health department, and they've declined funding or in-kind support upon principle. They're not 340B eligible because they are not receiving any qualifying funding from a Section 3 authorized grant. They have turned down all of that. Even though they're doing activities that would qualify, that are in line with the grant, they're not receiving that qualifying funding or support. If End the Epidemics Echelon would like to change that and become 340B eligible in the future, They need to build relationships with their Hep C, HIV, or STD health department administrators and grants managers and see what kind of support or funding they can receive. So in the first scenario, they are not 340B eligible. If they went to register, the state level administrator would decline their registration into the 340B program because there's no arrangement of them receiving that qualifying funding. They are not qualified. Let's talk through the Down South Local Health Department. So the Down South Local Health Department receives funding from their state health department for Hep C, HIV, and STD prevention activities in their jurisdiction. They operate a medical clinic that serves their local communities. They keep medical records, and they also provide on-site pharmacy services. So let us know again what you think in the chat. In this scenario, the local health department does have a contract with the state health department and does receive funding that comes from a qualifying line of federal funding. They are a direct recipient from state health department funding, as many local health departments are. This organization would want to make sure that the state health department is aware that they're going to enroll in the 340B drug pricing program. They'll want to make sure that they have everything they need for registration and come to an agreement on what will be done with any revenue generated from the 340B drug pricing program. This may mean amending or updating any contracts, grants, or agreements to make sure everything is in writing. So if any of you guessed yes, the Down South Local Health Department is eligible to enroll in the 340B program. The light is green, however, there's a few considerations for Down South Health Department. And I'll pause there for question.
Erin?
Yes.
We have a bit of a refresher question.
All right, let's do it.
Take it right now?
Yeah, let's do it.
Yeah, let's do it. Okay. From Anonymous, wondering if the Hep 340B program covers reduced prices for all HIV, STD, Hep drugs, or just Hep drugs.
Excellent.
Oh, sorry.
No, finish the question.
Yeah, if you are receiving Hep in-kind services, then you get access to all reduced drug pricing.
Yes, so I got a lot of feedback from my nightclub example, so we'll bring it back to that. But to address the first part of the question, the 340B program is not just for viral hepatitis programs. It is a very large federal program, and there's 16 covered entity types. Hospitals take up a big chunk of this program. So the STD designation is just one designation in many. To answer the second part of your question, I like to refer to the 340B program as a nightclub. There's a velvet rope that you're standing in line to get into the nightclub. Once you meet the eligibility requirements, meaning you receive an eligible grant funding, contract agreement, or in-kind support, you can get into the nightclub. You are in the 340B nightclub. How you behave, what drinks you buy, who you talk with and partner with, that's all up to you. So yes, once you are in and you are a qualifying provider and you're serving patients that meet that patient definition, you can prescribe or dispense or administer any medication that is clinically indicated. So that means that if somebody shows up to your clinic and you are authorized on viral hepatitis money, you might run through a risk assessment with me. You would ask if I inject drugs, if I've been incarcerated, if I was born between certain years. You would go through a risk assessment that is in line with the hepatitis grant. In asking me all of those questions, you might also notice a wound on my arm that needs antibiotics. You also might notice that I need treated for an STD. You also might realize that my diabetes is out of control and I need insulin. All of that is clinically indicated. And since I've already met that patient definition, you can prescribe me whatever I need and it's covered under the 340B program. Because you're in that nightclub and you've met all of the requirements, you can order whatever drinks you want because you've met all of the qualifying requirements to be in that nightclub. And thank you, Anonymous, for that great question. Is there any other questions or follow-up questions from that question?
Yes, no, but I do have from Rachel, our friend in California, asked, and then I will leave it up to you, Erin, what space to discuss this, but really I want to get the conversation going and have participants engage as well. We don't want to just talk to y'all. So Rachel asks, can y'all talk about 340B and FQHCs? Don't they have their own avenue outside of HEP department grants? Is it HRSA Bureau of Primary Healthcare funding qualifying under 318?
That is a great question, Rachel, and very timely because we were discussing this yesterday. Again, there are 16 different covered entity types. Each entity type is tied back to a qualifying grant type. So you're right, the Office of Primary Care gives out grants for FQHCs. There is an FQHC specific designation. You could argue that viral hepatitis treatment and care is a function of primary care. And I'm not intimately familiar with the grants that qualify FQHCs, but it's my understanding that it is for primary care for underserved individuals. So FQHCs have their own patient definition, just like viral hepatitis programs have their patient definition. Because remember, the services or scope of services must be in line with the grant. So you could potentially reach out to an FQHC partner or friend or organization and ask them about their grant, ask them how they interpret the patient definition, ask them how they administer the patient definition, and then identify points for collaboration, because the activities or the scope of the viral hepatitis grant might also be in line with the FQHC's grant.
Lovely. All right, that's all the questions I have for now.
Awesome, perfect. Okay, I was going to pause there for questions anyway, because our next slide is talking about registration. So if there's any more basic questions, I'm happy to take those. If any come up, we can also talk about those. And you can see my face on YouTube, which is slightly alarming, but there's a link to the previously recorded session. I couldn't watch it, but if you want to watch me, I support you in doing that. All right, once you or a subgrantee determine they're eligible for 340B, now what? And I realize now that there's a controversy with The Bachelor, I probably should have taken that image off. So I will acknowledge the racist institution that The Bachelor is, but I had to put a rose up there for eligibility. All right, let's discuss registering for 340B. Remember, an eligible entity has to serve eligible patients. So once all of that is squared away, you can register in the 340B program. There are 4 annual registration periods every year. It's the first 15 days of every calendar quarter. It does not matter if they're business days or weekends. It is always the 1st through the 15th of January, April, July, and October. The register button on the Office of Pharmacy Affairs website is only accessible during these open registration periods. So if you go now and look, there's no registration button. That registration button only pops up during these 15 days of every calendar quarter. Office of Pharmacy Affairs takes 3 months to verify registration and activate your registration. You may not purchase or dispense 340B drugs until your registration becomes effective. So in your planning, you need to think 3+ months ahead of implementation, depending where you're at in the calendar year. So ideally, you would know when a registration period is coming up and you would work backwards towards that. A lot of times programs see these deadlines and freak out. I don't want that to happen because I know April 1st is coming up. Make sure your house is in order before you run and register into the 340B program. We'll talk about all of this later on in the slides, but you need to make sure you have grants and contracts in place and signed and executed. You know how long this takes in bureaucratic environments. You have to route the paperwork, wait for the paperwork. You also have to make sure that you know how you're going to procure your medications. You might need to find a pharmacy. You might need to issue an RFA. You might need to find out who's an approved vendor. There's a lot of work that goes on before registration. So it might be a 6-month, a 9-month, a 12-month process. But just rest assured that every 3 months, a registration period will pop up. So if it doesn't work for April 1st, you'll have another 3 months to figure out your house. Make sure everything's in order. Ideally, each location has its own unique 340B ID. This limits audit liability and compartmentalizes operations. This might not work for how your organization is set up. I know we've got health department partners that operate in centralized as well as decentralized systems. And of course, there's lots of special considerations. I'm happy to work through anything with you, but ideally, the service level site would be registered as the 340B covered entity. There's also a new requirement upon registration. As of August 1st, 2020, STD, TB, and Ryan White entities are required to enter into the Office of Pharmacy Affairs Information System the Notice of Funding Opportunity Number, the NOFO number, the date range of their NOFO funding, and the type of in-kind support, if applicable, that they're receiving. If you already are a covered entity and you're already in the Office of Pharmacy Affairs Information System, you'll need to provide this when you recertify annually. So I don't think recertifications happened yet for 2021, but when recertification does roll around, you'll need to have all of this information ready to go because it's a new requirement. All right, when an STD, HIV, or viral hepatitis subgrantee applies to register, like I said, they'll need to provide the NOFO number. I put up on this slide where your NOFO number is. It's circled in red. That's public information. NOFOs are available just upon Google search. HRSA will contact the principal investigator or PI responsible for the CDC NOFO at the state directly funded prevention program or the directly funded local jurisdiction. And they will verify that there's in-kind support or funding being received at that agency. You'll also need to know the grant number. I've also circled that in red. Grant numbers are not public information. Grant numbers are specific to the funded organization, and it might feel counterintuitive to share this very secret number, but anybody registering will need to have a grant number, just like that previous slide stated. You'll need to know the NOFO as well as the grant number. So any subgrantees registering in the 340B drug pricing program will need to reach out to their state level administrator and get that grant number. When I was a state level administrator, I didn't share that ahead of time. I let everybody know to reach out to me when they were registering, and I would provide that grant number. Or I would send the grant number out maybe to anybody who I knew was going to be registering when that registration period opened, which I knew was going to be the 1st to 15th of every calendar quarter. So it really just depends on what your partners and subcontractors and subgrantees are going to be doing when registering and what you feel comfortable with doing. And also on the slide, I put how to find your statutory authority listed. So again, you'll need to know if a qualifying line of federal funding is eligible. It needs to be Section 318 of the Public Health Service Act. I looked in this NOFO that's listed on this slide. I did a control find and I searched for Section 318. It was on page 8 and page 34. So you can search through any NOFO and you can look up statutory authority. And in that statutory authority section, it's a mouthful, you'll find out what section of the Public Health Service Act that federal grant is authorized under. So if you need help working through that, I'm happy to assist you. Just a little bit of sleuthing around, and any information that you don't have, a state level grant administrator can also help you find. Authorizing official. This is another piece of the puzzle that you need to know when registering for the 340B drug pricing program. The authorizing official is responsible for 340B compliance and program integrity. They're responsible for certification and termination within the jurisdiction. They're also responsible for the covered entity's protocols, policies, records, all the important things. Authorizing officials range from program managers to chief operating officers or executive directors. This really depends on how your organization is set up, what delegation is given to what level of supervisor or manager. And it really just depends on who feels comfortable doing what. Within hospital systems, the authorizing official is usually the top dog. They're the person who signs off on all important documents, can legally bind the organization, signs all the contracts. The primary contact is usually more of a day-to-day administrator. They're the ones that intimately know the program, they operationalize the program. They're maybe a manager, a clinic manager, a program manager, an administrator, or an assistant. In some instances, health department prevention managers may be serving as authorizing officials, and some of you on this call might be authorizing officials as well. And I would encourage my health department friends to ask yourself, is it appropriate that I serve as an authorizing official? There's pros and cons both ways. And ask yourself, can you legally bind your organization to an agreement? And if you can legally bind your organization to an agreement, are the necessary papers in place that verify this? And what is the benefit versus the risk of program staff serving as the authorizing official? Someone may delegate you as the authorizing official, but you might not be comfortable with that. Or educating your chain of command and getting the top dog on board might be a lot of work, and it might be a lot of hand-holding to get the appropriate person who should be serving as the authorizing official to do so. Whatever your situation is, whatever your level of power and authority is, make sure your chain of command is aware of the program, that they're aware of the 340B requirements, operations and liabilities. My favorite acronym, especially in government work, is CYA. Cover your ass. That's all you need to know on that.
Can we, Erin?
Yes.
Do a little processing? Can I shoot you some questions from?
Yeah, absolutely. Yep.
All right, great. So while we're simultaneously processing, we're going to take it back a little bit, just a little bit. So first question, follow up to the question about treatment for STD and Hep C. Thank you for your example and with the patient that has multiple conditions. Does that mean that the clinic can now apply for reimbursement for all the medications provided to that patient, not just Hep C medication?
Reimbursement to an insurer payer, not necessarily reimbursement to the health department who is giving you the viral hepatitis funding. So the two kind of different mechanisms, when somebody shows up at your clinic, they might have a payer in the form of a private insurance provider. You can operate just how you would any situation. You can bill for those services, they're clinically indicated, you have a licensed provider providing them, all of that is billable. Yes, you can create revenue on all of those prescriptions. In some instances, the state is giving you money to buy medication. Your state level administrator might have strong feelings about you buying insulin or antibiotics or other things that fall outside of the scope of the grant. So depending on your situation, absolutely bill and generate revenue for any clinically indicated medication. Check with your state level administrator of what your grant funding covers. Does that make sense? Did I delineate that appropriately?
I think so.
Okay.
Yeah. Yes. And thank you for the question. Nadine. So we have another one from Nadine. Thank you so much. Okay. Regarding registration, when the qualifying 318 grant starts in May, for example, can the entity apply in April in order to be enrolled in July? Or does the entity need to wait for the qualifying grant to start before applying?
Excellent question. You will have to list what date your support started when you register, and it can't be in the future. It has to be right now. So when you're registering, you have to be qualified at that moment. So you would need to wait till the next registration period. That's a great question.
Yeah, that was a great question. Nadine said, yes, thank you. Well, thank you, Nadine, for the question. All right.
Yes, thanks for interacting with us, Nadine. We
right?
needed it.
Yeah, that's what we want. All questions are valid. Okay, we have one from Lauren. Our STD program requires very rigorous department from each participating org. They require the org to collect information by individual receiving in-kind support, and they have to submit this regularly to our STD program. This helps STD with audits. Should HEP programs be doing something similar?
Lauren, you are doing a great job of CYA. Your CYA is off the hook. I think it really depends on what your viral hepatitis partners feel is an appropriate CYA for them. Like your CYA is airtight. There is no way your ass is not covered. Viral hepatitis programs might not have the administrative capacity or bandwidth to do it to that extent. It may be an example of covering it in a memo of saying, this is what our patients receive in every encounter. So they're not providing client level information, but they might just be providing a policy or a program description. So it doesn't have to be to that level. Again, it's what you feel comfortable with and what you have the bandwidth and capacity. And if you and your leadership and your legal department feel that your ass is covered, then that's really what matters.
Awesome. All right. We have one from Jesse. Can revenue be used for testing?
Yes, it can. There's no HRSA or CDC requirement on what you use your revenue for. It is strongly encouraged to use it for reinvestment back into your program. You're morally deplorable if you use it for any other reason. So in providing testing, expanding services, improving quality of services, those are all great utilizations of revenue generated. Pay for labs, pay for additional testing, pay for socks or hand warmers, water bottles, whatever your program decides is within the scope of the grant that is supporting your patients, then that is an appropriate use of your revenue.
Awesome. Okay, we have from Rachel. I'm reading it now. Oh, look, that was for Atlas. Okay, I'm gonna read it aloud. Let's start this conversation. I don't think every patient needs to receive in-kind support. Isn't it the covered entity that needs to receive in-kind support, and every patient needs to receive a qualifying service like a sexual health risk assessment?
Yes, let's go back to the patient definition. Oh, hold on. Oh, went back too far. Losing my mind. Okay, yes. So there's kind of a two-part. So the organization has to meet the eligibility requirements, and then patients also have to meet eligibility requirements. So in Lauren's example, that in-kind is directly attributed to patients, and that's great and that's fine. But Rachel, you're also right, because the eligibility for the organization, you can describe what in-kind services are being provided. If a health department allocates you 100 test kits, you're qualified, you're in. You are receiving qualified Hep C test kits from a qualified NOFO. That doesn't mean you're limited to only serving 100 patients. So you're qualified and you're in the nightclub. Now, what you do in the nightclub is your own business. So you can serve thousands of people with your 340B drug pricing program, even though the health department only gave you a measly 100 kits. So giving that in-kind donation qualifies the organization to be a 340B covered entity. And how they administer the program and what patients they serve and what information they track on those patients is really how they're administering the program. So in Lauren's example, they might chart that they received condoms and a brochure, and again, her ass is covered. If Rachel just has a memo that says we have risk protocols in place, her ass is also covered. So kind of a different way of administering the program. And this is a great question to show that each program at the local level is so different, and your policies and procedures are so different. There's no template for 340B policies and procedures. It really depends on your program operations, your resources, your bandwidth, and what you feel comfortable doing. So yes, you are right, Rachel. You are also right, Lauren.
Both and. Okay.
And this goes to show how complicated this program is and why we have this webinar series, because those are great questions and we could just talk in circles on both of them.
Absolutely. Yeah, we could, keep going. Okay, so I don't see any more questions. Let's keep on rolling.
Okay, cool. Let's see. Okay, so here is an example of STD covered entities that are hepatitis programs. If your state is up here, do not be alarmed. I have not violated any security. This is all public facing information. So OPAIS has a database that you can go in and you can stalk and search and look up all covered entities. If you're just curious in your state who is operating in the 340B drug pricing program, you can choose your state. You can choose all the covered entities and you can just kind of look around. You can also see contract pharmacies, and you can also see dates of recertification or termination. And if any of you act as primary contacts or authorizing officials, you might have gotten sales calls from pharmacies or benefit managers. And it took me years to realize that people were getting my phone number off of this public information system. So when you register, don't provide information that you don't want to be public. So use a work phone number, use a work email, make sure that whatever information you're providing, you feel comfortable being accessible to the general public. And also don't let the covered entity type throw you. The STD designation is just the name of the designation for all 318 eligible programs. So just because it says STD does not mean it's not applicable to HIV and Hep C programs. If you're a viral hepatitis grant funded organization and you receive support, STD is the designation you're going to register with. If you're only doing HIV prevention activities or only doing PrEP through qualified 318 funding, STD is still your designation.
Erin?
Yes.
I think I found the site and I think I sent it in the chat, but just to verify, it's 340BOPAIS.hrsa.gov.
Yep.
Right? Okay.
Yep. And on that web page, there is a covered entities and a contract pharmacy, and you can click on either of those blue buttons and you can search around. And I encourage you to do that and become familiar with it. It's a wealth of information. And like I said, if you want to know who else in your state is operating under a 340B designation and what kind of designation they have, it's a great tool to do that.
Okay, awesome. Thank you. And I put them both into the chat box.
Awesome. Is there any other questions on this slide specifically or about the STD designation? Keep on trucking.
Keep on trucking. I will say, if folks want me to ask anonymously, I will interpret a direct message to me as you want to be anonymous, and all questions are valid.
Yep. I still have questions. All right, here's a little checklist. And again, make sure your house is in order before registering. You want to make sure any grants, contracts, agreements are all signed and executed before registering. You don't want to rush this. You don't want to be running around trying to get signatures. You want to plan this into your program implementation. And always remember there's another registration period coming up in 3 months. So this might feel urgent. You might feel like people's lives are depending on this, but just know a 3-month delay in the timeline of government bureaucracy is really not that long. So a checklist here, you want to determine who your authorizing official is, determine who the primary contact will be. You want to create a account within the HRSA Office of Pharmacy Affairs 340B information system. And like Isabel said, it's probably in your chat. Know your NOFO and know your grant number. That might mean that a covered entity or subgrantee might need to make contact with a state level administrator. Know if you receive direct financial assistance or in-kind support. You need to know and understand and figure out how you're going to be procuring your medications. And our next session is going to be all about medication procurement. But if you're going to contract with a pharmacy, the contract pharmacy also needs to register. They are tied to the covered entity, so they need to also register. You can't be a covered entity and just start contracting with Walgreens. They need to be tied to your 340B ID number. Also, you need to add no reply at hrsa.gov to your email program spam filter. This is the email that all of the notifications are going to be sent from, all the communications are going to be sent from. So just make sure that you don't miss anything. A little checklist for you. Okay, I'll pause there because I think the next slide is moving to roles and responsibilities. Oh no, sorry, it's annual recertification. We'll pause for questions after this. So once registered, entities must recertify annually and attest to program compliance. Annual recertification is usually a 30-ish day period in which authorizing officials need to log on to their OPAIS account and recertify their covered entity. It's a very secure double authentication system. I know many big important decision makers often delegate access to a lot of systems. This is one that's hard to do that in. So make sure that your authorizing official is educated and aware of the timeline, the importance of recertification, the role of the 340B program that plays within the organization. Emails are sent to both the primary contact and the authorizing officials. Oftentimes, primary contacts keep authorizing officials accountable and make sure that they complete the task of annual recertification. Failure to recertify will result in termination from the 340B program and will cause the organization to need to re-register, re-enroll, and they'll be held to all the same timelines, which is that 3-month hold on registration. You have to wait for the quarter to open up registration. So once you're in, make sure that you recertify. And I will pause there if there's any questions about registration or recertification before we talk about roles and responsibilities.
I am reporting that there are no questions in the chat box, but also I think folks can, oh, we have a question. But before I get to the question, before I lose my train of thought, folks can, I think, unmute themselves and ask, just putting that out there. All right. Nadine asked, you may have mentioned this before, but at what point does the registering entity receive notification that they are eligible?
So the HRSA and OPA say it can take up to 3 months. So sometimes you'll get an email notification sooner than that. Sometimes it will be exactly 3 months from your registration date. It will just be, you'll be eligible, or you'll be in there, you'll be active. So I would recommend, one, be proactive and just keep checking the database and checking your email and spam filters. And you can also reach out to them, but really it's a federal organization, so plan on that 3-month timeline that they give.
No questions are coming through in the chat.
Okay, let's walk through another example. So the Rainbow Bright Center, they have been collaborating with the state for over a decade. They are a great public health partner. They participate in the state's planning groups. They receive condoms, they receive rapid test kits, and they have recently just signed a contract receiving financial support to hire a Hep C patient navigator. A program administrator was sitting in on HepTax 340B webinar series when they were hit with the realization that they might be eligible for the 340B drug pricing program. They reached out to their state level administrator to make sure the funding in their contract came from a Section 318 NOFO, and great news, it does. They have just executed a contract with the state health department, as well as a great contract pharmacy. They meet with both their state level administrator and their contract pharmacy and have amended both of their contracts to account for the revenue they intend to generate. They negotiate a $25 dispensing fee with the pharmacy, and the state level administrator has stipulated that any revenue generated must be reinvested into the viral hepatitis program, supporting the purpose and intent of the grant. The Rainbow Bright Center discusses the 340B program with their executive director, chief financial officer, their medical staff, and board of directors. They have determined who their authorizing official will be, who's the executive director, as well as who their primary contact will be, which is going to be the medical manager. They both create accounts in the Office of Pharmacy Affairs Information System and add the email to their spam filter, so they will receive all of OPA's notifications. On July 1st, the Rainbow Bright Center and their contract pharmacy both register in the 340B program and have access to 340B priced medications beginning October 1st. Everyone celebrates and enjoys the fruits of their labor and starts getting everyone treated for their Hep C. Do you have any questions on this hypothetical scenario?
I have a question.
Okay.
That is not on this hypothetical Rainbow Bright Center, but I'm going to ask it.
Okay.
All right, great. If we have sites that already use 340B that never registered due to not knowing they needed to, previous program failures in parentheses, will they have to stop providing 340B services when they register? I know we are out of compliance.
First of all, I operated a 340B program that was out of compliance for years. So this is a safe space for you to fix that. I know the panic and dread when you realize your misstep. So if you would like to talk offline about how to proactively remedy that, I am here for it. I am your safe person. I am not a federal employee. I can help provide support for that. But I'm unclear how somebody was operating a 340B program without registering, because without a 340B ID, you cannot get medications. So maybe the person who asked this question could provide a little bit more information. Was it a scenario where somebody else was providing the medications and giving them to the organization?
Centralized system.
Okay. So we'll talk about this. This is called drug diversion, which is a very scary term, which means that one 340B covered entity is buying medication and then giving it to another organization who is actually providing the service. So this is not an uncommon mistake. So it might be a situation where a state or local health department is buying the medication with their 340B ID, with their pharmacy license, with their centralized distribution, and then they're giving it to a really great public health clinic who has great intentions, and they are seeing the patients and they are providing the care and they're providing the medication. So they are taking medication that was purchased under somebody else's 340B ID. The chain of command and chain of hold on that drug is all sorts of screwed up, and it's ending up at a clinic and ending up with a patient, and that is not an auditable record. And that technically is called drug diversion, which again is a very terrifying term, but very common thing to do. STD programs also are notorious for doing this. I myself used to drive bottles of zithromycin all over the valley because providers needed to treat STDs. Very, very common. The stakes are higher, obviously, in viral hepatitis program because the cost of medication for viral hepatitis is significantly more than a bottle of azithromycin. But you can remedy this. It takes a lot of work. You have to build up the capacity of that really helpful, willing clinic, because that helpful, willing clinic should enroll in the 340B program. They should be their own covered entity. They should be attesting to their own compliance. They should have their own authorizing official. If you still want to support them in the medication, you grant them money to pay for the clinical time, the administrative support. However, you still want to support them, and then they're receiving money and they're qualifying, but you have no liability in their medication and you have no liability in their compliance, but you are being a great public health partner in allowing them and supporting them and building up their capacity to be their own covered entity.
Awesome. Yes. Yes. State buys meds and sends out. Okay.
Yeah. And great. I'm so glad that you have realized that this is not how it should be done, because that is the first step. The first step is admitting you have a problem.
I put up my applause emoji. Okay.
Excellent.
Question. Yay.
Okay.
All right.
Any other questions on the example?
On the example.
Or anything else before we move on to roles and responsibilities?
No, I have two more questions. Okay, I'm reading them as we're speaking. Okay, all right, I think, yes, okay. This is from Michael. If a patient is reinfected with HCV and is treated again, does 340B pay the reimbursement again?
So your insurance provider might have thoughts on this, but 340B doesn't care. The 340B program is not keeping track of how many times you treat STDs, hepatitis, proctitis, cellulitis. They don't care. You can do whatever you want according to 340B. The payer source who is reimbursing may have thoughts on this. So check with the patient's insurance, because they're the ones that are going to be paying for the treatment.
Awesome. Okay, we have a question about the Rainbow Bright Center. Can this center get reimbursed for medications provided prior to October 1?
No, because they were not enrolled in the 340B program and they were not a registered covered entity.
Awesome. All right, we're good with questions.
All right, we have a few more minutes. We'll go over health department roles. So we've reviewed the registration process. We've talked about who should be the authorizing official. Let's talk about the role of health departments in all of this. The health department's role really depends on where the services are happening, what organizations they're contracting with and supporting. And remember, this is both financial and in-kind support. Health department roles may also vary from centralized to decentralized systems. So if you're a centralized system, you might be an authorizing official for 7, 10, 15 sites. In a decentralized system, you may not. It really depends on who is the legally binding person for the agency. In a centralized system, there might be one legally binding person for multiple sites. So that gets a little bit more complicated. So it just really depends on how you're set up, where services are happening, and who's going to be considered the covered entity. And for health department folks, you need to know, you might need to know all of this for you if you are the covered entity, or you might need to know all of this because you're supporting your subgrantees in them being covered entities. Either way, this is really great information to know because you will save lives with this program. This increases access, this improves health equity. So regardless of if you are the covered entity or your subcontractors or subgrantees are the covered entity, it's really great to have a working knowledge of this program. And also, I want to reiterate that ultimately every covered entity is responsible for their own 340B drug pricing program administration. They are responsible for their own compliance. Were you just amening me or did you have a question? Okay, perfect. Moving on to our slides. Again, I've listed out the roles that health departments play in all of this. You need to ensure that your subgrantees know about the 340B drug pricing program, provide guidance regarding what is considered a service within the scope of each CDC NOFO. You might need to walk through with them what activities are in line with the scope of the grant. Understand how subgrantees are meeting the patient definition. You may review their policies and procedures if you have the bandwidth or if you feel that you would want to do that. You can also set that up in a contract or agreement that you will review their policies and procedures. It depends on how you want to administer the program. Health departments should set clear expectations regarding oversight and compliance. Remember, each covered entity is responsible for their own compliance. They are all answerable to HRSA, Office of Pharmacy Affairs. Be familiar with how your subgrantee will be purchasing medication. Update your contracts and agreements to account for all 340B considerations and revenue. Be aware of registration and recertification periods so you can support your grantees and ensure that they have grant numbers and NOFO numbers and all of their questions are taken care of. You also will verify to HRSA, Office of Pharmacy Affairs, that they are indeed a subgrantee when asked. When your subgrantee registers, HRSA will reach out to you, the PI or the state level administrator, to verify that they are receiving support or in-kind services. That also means that you need to notify HRSA and Office of Pharmacy Affairs if a subgrantee is no longer receiving funding or in-kind support. And just as important as what your role is also what your role is not. You should never enroll a subgrantee into the 340B program for them. You should never serve as a subgrantee's authorizing official or primary contact. Remember the description of who should be an authorizing official. It's whoever can legally bind the covered entity. It is my recommendation that you do not serve as the authorizing official for any subgrantee. Can you legally bind them to an agreement? Can you attest to their compliance? The answer to both of those questions is no. No, you cannot. So each subgrantee should have their own covered entity, their own 340B ID. You should not create policies or procedures for them. As a state level administrator at the health department, you can review them, you can provide capacity building, you can provide technical assistance. It is not your responsibility to write them for them. Let's see, you don't have to audit their 340B compliance. Remember, health departments or subgrantees answer to HRSA and OPA for their own 340B designation. Health departments are not required by HRSA or CDC to provide oversight for their subgrantees' participation in the 340B program. However, we recommend that health departments provide guidance regarding 340B in their contracts or subgrantee agreements. Ultimately, all covered entities are responsible for their own 340B compliance, and every 340B program must attest to compliance and can be audited by HRSA, Office of Pharmacy Affairs. So again, it just depends on your capacity, how involved you want to be. And also, please do not take everyone's 340B revenue. It is not your job at the health department to take their revenue. It is your job to be good fiscal stewards of federal funding. It is your job to make sure that any revenue is reinvested in the program. In some instances, it may be appropriate to share that revenue. That revenue should be very clearly delineated in any contracts and agreements on what your expectations are. And resources slide, I shared that last time. And a quick summary, I know we're at time. Summary for this session today: ensure eligibility is met, patient definition is understood, understand the roles of the authorizing official and primary contacts, make sure you designate the right person, make sure contracts and agreements are in place ahead of registration, register in and be familiar with the Office of Pharmacy Affairs information system, be aware of the 4 registration periods, be ready for annual recertification period, and support your subgrantees. And we have no time for questions or workshopping, but if you want to throw some in the chat, we'll try to knock some down or include them in future sessions.
Yes. All right, we have one from Liz, our friend in Iowa. All right, our health department's responsible for monitoring revenue generated by subgrantees to ensure it is reinvested back into the program. What is the role of the health department if it is not?
So if that's your role as you see it, I support that. I'm communicating that there's no expectation from HRSA or CDC that you do that. If you as a state level administrator want to do that, feel comfortable with that, think that's an appropriate role for you, I'm here for it. There's no statutory authority or requirement that you do that.
Awesome. Okay, now because we are at time, Erin, I received a few anonymous comments in that you have done a great job to communicate a very complex and arcane program.
Thank you, everyone.
Excellent webinar. I appreciate you for the support in this. Even though I'm part of this and I've been a part of this for a while, it's still very complex.
It is very complex and each situation is so different. If there's something that you want to workshop or talk through, email. I should put the email on this slide as well, but email in, we can set up a one-on-one TA session. I do have time set aside for those situations. And again, we'll have another session on Wednesday, April 7th. We'll talk more about contract pharmacies. We'll talk more about medication management. We'll also review the first 2 sessions. So that might take up a lot of time as well. And then we'll talk about compliance considerations as well.
Yes, send your questions. We'll do a refresher. This has been recorded, will be shared. And thank you everyone for your participation and your questions and your interest.
Thanks, everybody.
Awesome. All right, y'all take care.